Thank you for taking the time tonight to join us. Um, Let me start by introducing myself. My name is Eli Karam. I'm a fourth year orthopedic surgery resident based in Quebec City. I'm also a husband and a father to a 2-year-old princess that I hope is under control right now, but that's not for sure. So I'm sorry in advance. I'm also an AS warrior. I was diagnosed 2 years ago. It probably took around 4 years to have the right diagnosis. And I have to say, I'm grateful now that I can say that I'm almost pain free. And I've been almost pain free for 18 months. I recently joined the board of the CSA, and I really hope that I'll be able to contribute with this great association to raising awareness about this disease and other spondyloarthropathies in general. I'd like to thank all the partners that contributed for tonight's event. I'll start with a brief overview of the CSA, then we'll get to Dr. Chan's presentation, and we'll have a short period of Q&A. So who are we? We're a national association with the sole purpose to support those diagnosed with spondyloarthritic diseases. We're a federally registered, not-for-profit corporation that submitted an application for charitable status that we hope to have very soon. We have a board of 11 members that are all comprised of volunteers living with or affected by spondyloarthropathies. We have an amazing executive director and an awesome IT expert, Executive Director Wendy and IT expert Dan, that we both thank so much for the amazing work they're doing every day. What's our mission? It's basically to be the leading voice for spondyloarthritis, for the spondyloarthritis community in Canada, trying to provide support, education, advocacy, and awareness for patients, caregivers, loved ones, and healthcare professionals through innovation. We have 4 strategic pillars: education, information, advocacy, awareness, and support. We try to raise awareness through social media, websites, Facebook, Twitter, Instagram. We try to have a community support, group one-on-one, email, phone. We organize information sessions, webinars like this one. We try to have activities to raise awareness for patients, for the public, and very important for healthcare professionals. We also are involved in international awareness and community activities. We try to continue to advocate for medication. We recently added in devices and services. Our healthcare system, as you all know, can seem sometimes complicated. So patients can lack information and resources to understand how medication are reimbursed. We continue to shape policies, and although we do not financially support research at the present moment, we support those who do research, as we truly believe that it is through research that we will ultimately have the greatest impact on patients. 3 years ago, we started support groups. We only had 2 groups in Canada. We now have more than a dozen. I personally joined recently the Montreal support group. And I have to say, it was one of the most pleasant surprises of this kind of awkward year that we all had, at least for my part. I got to listen to inspiring stories and experiences and share my worries, my fears, and moments of joy with a group of amazing AS warriors. I'm truly grateful to have met them, even if it was only virtually this year. So if anyone is interested in joining or start a group, please do reach out. You can send us an email to support@spondylitis.ca, and we would love to help you join or start a group. We have an exciting lineup of webinars planned for 2021. So please do watch for notifications and updates on our website. Of note, we only provide information. This is not medical advice. The information here is presented and discussed. The information that is presented here and discussed tonight may not apply to your own medical condition. So please, if you have specific questions about your medical treatment, you have to refer to your own healthcare provider. So I'll leave you with the presentation of Dr. Chan. Just a reminder, your feedback is very important to us. So please do fill the short evaluation that we'll send afterwards. It's really important for us to get better and to try to serve you better, because that's the main objective of the CSA. So I'll leave you with Dr. Chan, who got his medical degree from the University of Alberta, his internal medicine degree from UBC, and he did his specialty in rheumatology at UBC also, and he also did a clinical fellowship in spondyloarthritis at the University of Toronto. He currently does mostly clinical practice, but also he's involved in clinical research in axial spondyloarthritis and psoriatic arthritis. He's involved in a number of international research groups and has helped with the writing of the Canadian Spondyloarthritis Guidelines and International Psoriatic Arthritis Guideline. He's currently an assistant professor at UBC and clinician investigator with Arthritis Research Canada. Thank you so much, Chan, for taking the time tonight. We're looking forward for your presentation.
Thanks very much for the intro. And let me just switch to this. Do you guys all see this? Yeah, perfect. Okay. So thanks for the intro. I'm John Chan here. So we're going to leave questions at the very end. You could type them in the Q&A section. And if I cut out or you don't hear anything, someone can flag me down to repeat myself. Let's see, this is, oh, there we go. So disclosures, I have participated in clinical trials, received unrestricted grants, meaning that they give me funds and I can do whatever I want with the funds to pursue research, participate in advisory boards, received honoraria for speaking from a number of pharmaceutical companies. I think the important thing is tonight is hosted by the CSA, and I'm not getting paid to give this talk. This is just me volunteering my time. And I try to give as unbiased an opinion as I can. But, you know, I think it's important that you know that I've received funding in the past from some of these companies. So tonight I was asked to touch upon 5 different topics. Here's an overview of different classes of medications, how they work, how physicians may decide when to pick one treatment versus the other, possible side effects, important of adherence, expectations, talk about the different treatment options, and also just to give an overview of what some of you guys might experience and what is a common experience for patients as they're navigating through our healthcare system. So oftentimes we would just start with a clinical example, you know, a fictional patient, but since I assume most, if not all of you here have spondyloarthritis, I think you guys could tell a better story than I can. And so what I could do here is describe some of the data we've received from this international map of axial spondyloarthritis. Now, just so you're aware, the classical, so some of the terminology, ankylosing spondylitis it is kind of the traditional term we use, meaning that there is evidence of damage in the sacroiliac joints on X-ray, we know that not everyone has X-ray damage. And if you catch people early, oftentimes you'll find things on MRI or CT. And so the bigger term is called axial spondyloarthritis. So that encompasses classic AxSpA in addition to people who have evidence of inflammation there, but don't quite have X-ray changes. And so there was this international map, this survey sponsored by Novartis. Basically, one of the patients in Spain who had axial SpA, he realized that a lot of the data that we get from clinical trials are things like back pain, reduction in inflammatory markers, MRI changes, which are nice, but at the same time, it didn't often address what the patient was experiencing. And so he sought to create this survey that might try to give us a better picture of what struggles patients with the disease have to identify care gaps. And so he approached Novartis, so one of the pharmaceutical companies, and they were generous enough to say, you know what, we'll give you funding, do whatever you want. We don't have any say. But they've kind of brought it to multiple countries around the world, and Canada has some of the highest uptake. And I thank a lot of my patients. I know in BC we had about 99 respondents, which was pretty good. We were right after Ontario, despite the fact that our population is not quite as big. And we had a good turnout. And it's with data like this that we can approach payers, the government, saying, this is the burden that patients are experiencing. This is the unmet care gap, and this is why we need expedited MRIs. This is why we need access to treatment, coverage for physiotherapy, educational sessions, things like that. So, the average Canadian patient with AS started symptoms at age 26, and there was a 9-year delay from when symptoms started to when they were diagnosed. 3 years longer for females, which is what we see in many countries. Now, the interesting thing is, if you can see my pointer here, there's about 50% of patients are diagnosed with 0 to 4 years of symptoms. So these are kind of the more recent. And in the last 5 to 10 years, there's a greater awareness of axial SpA in the rheumatology community and the medical community as a whole. So I think this is probably reflective of patients who, when AxSpA was thought to be a lot rarer than it actually is, that you had patients who were delayed for 20 plus years. And so this is encouraging, and hopefully this number just keeps growing as and these numbers don't. Average BASI. So many of you may have filled out these questionnaires of 6 questions, which were actually derived, they were developed by patients with ankylosing spondylitis. So I have a lot of patients ask me, who came up with these stupid questions? Don't blame me. It was actually patients who said, these are questions that are important to us. And so it's a way of measuring how active, how much symptoms patients have. And so the average BASI was 5.3, which is pretty high. 4+ is considered active disease. And on average, people saw 2.9 to almost 3 different healthcare providers before making a diagnosis. And, the most common tests were done were the HLA-B27 gene, X-rays, MRIs. And most patients in this survey were diagnosed by the rheumatologist, a few from the internal medicine specialist. I'm a little bit, curious to know the 19% who were diagnosed by their GP. I wonder if it was that their GP first did the testing, B27 happened to be positive, and they said, you might have ankylosing spondylitis, and then referred to the rheumatologist for confirmation. But it is not a super common disease, and so I would kind of rely. I'd be more confident if the rheumatologist was making that diagnosis. Now, orthopedic surgeons were making the diagnosis about 3% of the time, and when I talk to my colleagues in orthopedics, they still see occasional patients who have been missed for all their life, and they come in with a bamboo spine that fractures. And so the first time they meet a patient, or the first time that they've ever been diagnosed, was maybe at age 60 or 70 when they come in with a fragility fracture from their bamboo spine. So that's that's an area that we need to be addressing and capturing these people earlier. Now we know that spondylitis patients have pain and have stiffness, but I guess we never really captured how much it impacted their job. So in this survey, 43% of patients, and there's over 500 people who responded, stated that the disease influenced their job choice. 80% had issues with work related to AxSpA. About a quarter were scared of losing their job due to work, due to AxSpA. 70% had difficulty finding a job, and just over a quarter were in fear that AxSpA would impact their career development. I will say though, this was patients who volunteered to do it, so you might argue that maybe the people who are doing super well and not having any symptoms are busy with their lives and too busy to do surveys, and maybe people who have something to complain about tend to do surveys. That is a possibility. But needless to say, I think that we have 500 people, which is a substantial number, and about half of them are complaining about a severe impact on their work. And I think that's something we as clinicians need to pay attention to. And as patients, I think also be mindful, because a lot of the times this disease slowly creeps up on patients. If you had 2, 5, 10 years of symptoms before you get diagnosed, a lot of the times function starts declining gradually. And so I do see some patients who tell me, I don't have any pain, their BASI scores are 2s, or I've got 1 or 2 out of 10 pain, very minimal, but I've stopped working or I had to switch jobs. And so I would say that in those situations, I would lean towards escalating therapy, because that might suggest there is some room for improvement there. And I'll talk a little bit about that later. So an overview of different classes of medications and how they work. Now there is, exercise is also very important, and I'm going to talk about that closer to the end of the talk. But that was a question that Wendy had asked me to address. And so 3 main classes is NSAIDs, anti-inflammatories, biologics. So these are complex proteins that are man-made, and they bind onto inflammation chemicals in the blood. So when inflammation is if you Google that term, a lot of people talk about inflammation, and it means a lot of different things to different people. So some people mean stiffness and swelling and pain. When a rheumatologist is talking about inflammation, we're talking about these cytokines that are entering the system. There is dilation of blood vessels, so enlargement of blood vessels. That's how you get the warmth and the heat, and all the inflammatory cells, the white blood cells, start pouring into these areas, often joints. And so, for example, if the knee is inflamed, if you put a needle in there, suck fluid out, you can see there's actually quite a high number of white blood cells compared to a healthy joint. And so a lot of the way the body's immune system communicates is through these inflammation chemicals. And 2 of the key chemicals implicated in AxSpA is TNF and IL-17. And the JAK inhibitors are pills that we've been using for about a decade in rheumatoid, been super effective. And actually just 3 weeks ago was the first published data for the phase 3 trials. And so I think in a matter of maybe months to under a year, we'll probably get access to JAK inhibitors for the treatment of AxSpA as well, which is good to have more options. So NSAIDs, these would include things like Aleve, Advil, Celebrex, Meloxicam, diclofenac, Arthurtec. Basically, they block the COX enzyme. And there are 2 types of COX enzymes, COX-1, COX-2. And if there's some kind of stimulus or membrane injury, these enzymes produce prostaglandins, which are part of the inflammatory process. And then non-selective NSAIDs will block both. There are selective ones which only block COX-2, so COX-2 inhibitors such as Celebrex and Meloxicam. And this is what we call a homeostatic enzyme. And so patients tend to get a little bit more GI upset for the non-selective ones. So if gastric upset, stomach bleeding is been an issue, a major concern, then you would lean towards either a COX-2 inhibitor, or you can add a proton pump inhibitor like Panaloc, or misoprostol. So Arthurtec is a combination of diclofenac and misoprostol. So that can be different ways of trying to troubleshoot that. Possible side effects. So, in a young person, there isn't a lot of risk. I would check their blood pressure every 6 months. I'd probably get their kidney function. And if the blood pressure is creeping up and the kidney function declining, then we tell people to stop. If you catch it early, it is reversible. If you wait years into it, there can be irreversible damage to the kidneys. So you should do some blood work monitoring if you're on it long term. If you take it for too long, though, it's not good for your heart. And so when I have patients kind of in the 55, 60 plus age category, I get a bit nervous and I try to wean them off if possible, because, this was initially studied in colon cancer. They wanted to see if they could treat people with anti-inflammatories to prevent colon cancer, It didn't work, but they found all the people on the anti-inflammatories are getting heart attack. Well, there's a higher incidence of heart attacks. It's not like everyone who takes these medications will get a heart attack, but if you look at people on the treatment versus people on a placebo, more people were getting heart attacks on treatment. And when I look at the data, it's about a 30% increased risk from their baseline. So it depends on what your baseline risk is. And the cardiologist will say even 10 days of anti-inflammatory will increase that risk by a little bit. So we don't know what the safe amount of anti-inflammatory is, but if you're getting up in age, I get a bit cautious with continued use of anti-inflammatories. Stomach ulcers are actually pretty common, but not all of them bleed. They can cause stomach upset. You put a camera down, the gastroenterologist can see there's some ulcers there. Stomach bleeding is actually probably about a 1% risk. And so that's something else to be mindful of possible side effects. TNF inhibitors, many of you may have heard of these. So these are 3 forms of etanercept. These are 3 forms of infliximab, adalimumab, certolizumab, and golimumab. Those are the brand names. Just I think a lot of people might recognize those more. So what they do is they bind onto TNF, which is an inflammation chemical. And there's different ways that it can do that. So etanercept, Enbrel, Erelzi, or Brenzis, was basically it's a soluble receptor. So what happens is the TNF molecule usually comes, it docks onto a receptor on the surface of a cell. So it's kind of like a spaceship coming to the space station. It docks on, and once it locks on, then it sends a signal down the cell to start propagating the inflammation cascade. And so the soluble receptor is a bunch of decoy docking stations. So the TNF binds onto the decoy docking stations, and the signal never gets passed through, and it kind of breaks the chain there. Infliximab is another molecule here. And so you have basically docking stations here and this FC portion that gets the immune system to clear the TNF out. And there's a little bit of mouse gene here. Golimumab and adalimumab were fully humanized molecules. And then certolizumab is a docking station with a large PEGAL side chain. And so all of these are pretty effective. And we think there are very few head-to-head trials in the TNF inhibitor world, but the ones that we do have do suggest they're pretty similar in efficacy. And many of you may have heard of biosimilars. I'm just going to give a brief, briefly touch upon that. Biosimilars are basically the same protein structure, but they have slightly different sugar molecules. So one of the questions was, are they as good? Are they different? And if you switch, is there a concern there? So there's at least 10 randomized controlled trials. So that is kind of like the pinnacle in medicine, where you take 300 people, half of them get one drug, half of them get the other drug. No one knows what they're taking, and you follow them for a year and see what happens. And all the studies suggest that they're the same in efficacy, same in safety, immunogenicity is the same. In fact, the newer molecules tend to have less injection site reactions because they just have a different needle tip, and sometimes the stabilizing liquid is different, and so they tend to have less of these injection site reactions, but the efficacy is the same. So the next question is, if you have people who are stable on a bio-original, is it safe to switch them? Because the biosimilars are significantly cheaper. And so in BC, they kind of mandated everyone on these drugs to switch. There have been a number of switch studies where after 1 year, about 300 people get Enbrel, the other for about a year, 300 people get Brenzis as an example, and then they're all equal. And at the end of the year, all the people on Enbrel switch to Brenzis. So they compare the people who continued on Brenzis the whole time and the people who are Enbrel and then switched to Brenzis. And again, there was no difference in dropout. The other thing to be mindful is of every year, roughly 10% of people lose efficacy. So if you switch and you lose efficacy, it's hard to know, is it because you switched or is it because you would have lost efficacy anyways? And about the 5-year mark, about 50% of people, it started working and it stopped working. And thankfully, we have a lot of other options there. That's just a little bit about biosimilar. And then there's also multi-switch studies. So they've done Enbrel versus Erelzi. So one arm got Enbrel, one arm got Erelzi, one arm every week got a different drug, and there was no difference at the end of the year. And then in Norway, they switched half the country, or they switched most of the country, but 25% stayed on Remicade, and the other 75% switched to one of the biosimilars, and they didn't have any loss of efficacy there statistically. I mean, some people lose efficacy in both arms, but there wasn't a higher rate of loss in either arm. So, I mean, you can make it's a bit of a political landmine, I think, sometimes for these things. But in terms of cost savings, this is, I often tell patients 25% of our healthcare budget goes to pay for these medications. And if there is seemingly no difference in efficacy or safety, and one-time switches seem to be fairly safe, this is estimated to save about $1 billion in Canada if we mandated switches. So that's for the politicians to decide. In terms of possible side effects, injection site reactions are, they happen depending on which drugs. Some drugs have a little bit more of the injection site reactions. They're not dangerous, but they can be a bit annoying. There's some ways of troubleshooting that. The main risk is risk of serious infections. And so by serious infections, that's anything requiring antibiotics or hospitalization. And so when you look at these studies, the placebo arm on average gets about 2% risk of these serious infections. So if you got fake drug, 2% of the time you'd get an infection. And then on the treatment arm, it was about 3%. So it's about a 1% absolute increase. And that's roughly a third, I say a third. So sinus, pneumonia, bowel bladder was about a third in either. One of the big questions is whether these things can induce cancer. And so because TNF does kind of march along the cancer pathway, so people were watching closely. In Europe, there's these large registries because they wanted to capture this. If you follow people for 15 years, is there this huge deluge of cancer? And the largest studies I've seen is 150,000 patients followed for 15 years, and they didn't see any increased risk of cancer, with the exception of non-melanoma skin cancer. So there's different types of skin cancer. Melanoma is the real aggressive one. The other two are non-melanoma skin cancer, so basal cell, squamous cell. Typically, you would just cut those out and continue treating with the medication. Of course, if someone has a history of active cancer, you may be cautious, and oftentimes you may need to treat that cancer anyways with some other form of medication, and there might be some interaction there. So you'd have to discuss that with your oncologist or rheumatologist there. There's about a 1 in 1,000 risk of drug-induced multiple sclerosis, lupus, and psoriasis. Typically reversible. The one case that I've had where it did not reverse, the patient had a strong family history. Father and brother had multiple sclerosis, and at the time there was no other treatment option, so they took the risk, and unfortunately they ended up getting multiple sclerosis as well. Now it also depends on the disease. So in Crohn's and ulcerative colitis, the risk of psoriasis with a TNF inhibitor is much higher than in patients with rheumatoid or psoriatic arthritis or ankylosing spondylitis. And we don't exactly know why that's the case, but paradoxical psoriasis is, it does change depending on which disease is being treated. IL-17 inhibitors, you may have heard of Cosentyx or Taltz. Basically, there are these Th17 cells that can produce IL-17. There are other cells that can produce it as well. IL-17 is an inflammation chemical that acts on a number of other cells. And each of these cells, some of them can cause blood clots, inflammation, damage to cartilage, erosions in bones. And so by blocking this has been shown to be very effective for psoriasis, very, very effective for psoriasis. Also quite effective for axial SpA and for arthritis as well. And so it's a good treatment in our armamentarium. In terms of possible side effects, injection site reactions are also possible. Infection risk, still about roughly 1%. It's interesting, if you look at the head-to-head studies, so they compare Humira with Cosentyx and Humira with Taltz, the efficacy is the same. In both trials, there was a little bit lower risk of serious side effects, but if you look at the actual side effects, it doesn't really break down into a neat box. So I can't say it's because of less infections or less, MS or something like that. So we're not sure if that's just random chance that that there were 4 in the Humira group and 2 in the Cosentyx and 2 in the Taltz group. It may just be random chance, but it does not have that psoriasis, MS, lupus risk. There is some caution if patients have active inflammatory bowel disease. And so it's another good treatment in the armamentarium. JAK inhibitors are pills. that they block these enzymes here. So when the cytokine comes, docks onto the cell surface, these two JAKs have to combine before the signal can come down. And there's 4 types of JAKs: the JAK1, 2, 3, and TYK2. And they combine in different combinations. So JAK1 and 2 and JAK1 and TYK2. And based on which combination, different cytokines can be blocked. And so basically, these are kind of like, I think of them as like ignitions. And so they're the spark plug that phosphorylate the STAT enzyme in that enters the cell nucleus and transcribes more or pumps out more inflammation chemicals. So when you block this enzyme here, you block the efficacy of that inflammation chemical when it touches the cell. And so there's 2 right now that are being looked at for AxSpA. So Xeljanz already approved for psoriatic arthritis, and I expect in a matter of months will be approved for AxSpA. It's just been submitted to FDA approval a couple of weeks ago. Rinvoq looks quite promising. They're currently doing their final studies before they get approved. Possible side effects: infection risk is about the same, about 1%. There is a higher risk of shingles, about a 3% risk of shingles. Now, thankfully, a lot of these companies will provide the shingles vaccine for free, and that really reduces the risk of shingles. So if you're thinking about it, you can greatly mitigate that risk with a vaccine. Interestingly, it actually bumps up both good and bad cholesterol. But the clinical significance that is unknown. So they've compared people treated with Humira versus people treated with Xeljanz. And there is higher levels of cholesterol in the Xeljanz group, but we're not seeing an increased risk of heart attacks or strokes. And so we think both good and bad are elevated, and it doesn't seem to, it becomes a wash. But, I think that's just something to be aware of. At double the dose, there was a slight increased risk in blood clots, but at the dose that's approved in Canada, we don't see an increased risk of blood clots. Having said that, if someone has a history of blood clots, I get a bit nervous. I probably pick something else. So how do physicians typically decide what to pick for their patient? I mean, this is what I do. I can't speak for every rheumatologist in the country, but the first thing I think of is what areas are active, because in AxSpA, you can get spine, peripheral joints, skin, eyes, bowels, and all of those behave differently. So you can have terrible skin, but really mild peripheral joints, and vice versa. So I look at what's the most active or which ones are active and pick a drug that's going to treat all of those as best they can. Sometimes you have to combine 2 different things or 3 different things to make sure you knock all of them. What are the contraindications? So if they have current cancer, I would not pick a TNF inhibitor. Heart failure, can't use TNF. Multiple sclerosis, can't use TNF. If they've got IBD, uveitis, or psoriasis, then you want to use a TNF. Well, at least these 2 for sure. IL-17 would work for psoriasis. Severe lupus, no TNF, risk of infection. Then you'd kind of debate about which TNF you may want to pick, because some of them have a lower infection risk than others. And then if hepatic or renal dysfunction or kidney or liver dysfunction, you probably can't use the JAK inhibitor depending on how severe things are. Other considerations would be frequency of injection. So some of them are once a week, every 2 weeks, once a month, or pills. And so some people prefer one or the other. Another consideration, maybe in BC, it's because we're more, I don't know if I want to say we're more socialistic, but I often tell patients, if all things are equal, let's say, I've got all these different treatment options and the efficacy's been shown to be the same. Now, I can't promise in you it's going to be 100% effective, but, the probability of a response is the same no matter what drug we pick. And the safety, there's no real reason to go one or the other, but the cost is huge difference in some of them. So the newer drugs, the government, at least in BC, has mandated that the drug companies come in at half the price. So we're talking about $20,000 versus $10,000. And this is not a cost difference to the patient. This is, at least in BC, it's a cost difference to the government. So I do frame it sometimes, if it's equal to you, if you could save some healthcare dollars, would you be interested in that? And some people say, no, I'm not interested. And other people say, yeah, that's something that would help me feel good about my decision. The other thing, the JAK inhibitors, those are about $15,000 a year, at least in Canada. I think in the US are much, much more. When they go generic, they're probably going to be about $1,000 a year, $1,000 to $2,000 a year. So that'll be a huge game changer for for kind of the cost to our system. And then of course I ask what worked and what didn't work. So if you've failed 3 TNFs before, let's pick a different mechanism of action. Importance of adherence. So, if you're not well controlled, there's a high risk of flare if you stop the meds. And I know a lot of the times when you get diagnosed with a condition, it's a new diagnosis. Oftentimes patients are younger and they've never been on treatment before. And now you're committing them to these biologics, which can sometimes sound scary, and often long-term therapy for most patients. And so as soon as you start feeling better, you wonder if you can start coming off. Part of the issue is if you stop it too early, it can reflare. And if you start and stop, there is a risk that the body just stops starts seeing that complex protein as not belonging and neutralizing it. So it may increase the loss of effect or expedite that. I also tell patients to imagine like a fire in the kitchen, and you want to treat it early and aggressive if you can. Now, I'm not saying everyone needs a biologic. Some people can manage with exercise or anti-inflammatories, but if you've got bad disease, you want to be aggressive about it, because we know that the longer you wait, the harder it is to treat. And I'll talk a little bit about efficacy down the road, but early treatment results in a higher chance of remission and a higher chance that you may be able to lower the dose and in some cases stop medication. If you wait 10 years, there's a much lower chance you're going to respond and almost a very, very low chance you're ever going to stop the medication. And tapering should be done slowly and under the supervision of your specialist. The other thing too, you want to treat that fire before it causes damage, because let's say you put the fire out. If you got all this damage on the walls, then the foundation could still collapse, and so you want to prevent that from happening. So there's a lot of these adherence studies, mostly rheumatoid. That's where and eventually it kind of trickles to the other inflammatory diseases. But we think it's a fair extrapolation to other types of inflammatory arthritis. But patients with rheumatoid with active disease, they kind of compare them to people who are adherent versus non-adherent. And it's not a huge surprise that those who are adherent tended to have better responses than those who were non-adherent. And then if you were adherent, you also tended to use having to see a GP less cardiology visits, less emergency department visits, less hospitalizations, home care, less rehab. All of these things you need less of if your disease is quiet and under good control. So, I mean, yes, these medications have possible side effects, but if your disease is active, that's an if, and it's based on your individual situation, and that's a discussion with your rheumatologist. The rheumatologist, if they're saying, yeah, you have active disease that warrants biologic therapy, the risk is probably outweighs the possible side effects. Now, and then concomitant drug use in rheumatoid arthritis, if you look at the people who are non-adherent, they tend to use more anti-inflammatories, more steroids, more prednisone, more injections. So just the better control the diseases, you have less of these flares. So different dimensions of adherence, there is the healthcare system, and that's, something we try to address as best we can, try to make sure people have access, and imaging and blood work, but there's also the condition. So if people have depression and other comorbidities, it sometimes makes it difficult for them to adhere. Patient knowledge is important. I think if people understand the importance of adherence and the important, why am I treating this, and what are the side effects if I don't treat, and what are the side effects of the medication, I think empowering patients that way is important. Less frequent dosing has been shown to have better compliance. So, if you're having difficulties with compliance, sometimes talking to a rheumatologist and they can troubleshoot. Is it because, if frequent dosing is just hard to remember? Are you traveling a lot and you can't take the pens in your bag? Maybe pills is a decent option. Or do you have a needle phobia? Maybe coming into the clinic for an injection might be helpful. So there's different ways of trying to address those. So what's your expectations? This is just the numbers we look at in our SPARC cohort. So SPARC's a research organization in Canada. There's a number of rheumatologists in most of the provinces that we meet, and we collect data from patients who are open to sharing their experience. We add it to a database, and then we can look at the database and say, what are the risks of infections? What are the risks of diabetes and cancer, and how are patients doing it? And that's often how we learn more about the condition. There is a bit of a selection bias. So, patients who I'm enrolling in Spark tend to be more aggressive than maybe your community rheumatologist, because I do see a lot of second opinions and see patients who might have failed multiple treatments. So there might be a skew towards more severe cases. But in our Spark database, about 10% of patients, did a bit of exercise, that's all they needed. Anti-inflammatories, about 30% of patients had very good benefit with NSAIDs, and about 60% of patients were on a biologic, and about a third of those patients were on both biologic and NSAIDs. Now, there's probably a lot of people who, do a bit of yoga or Pilates, and the back pain's gone. They have AxSpA, it's so mild, they never see the doctor, and that's fine too, right? I don't think those patients necessarily need a biologic. So I talked about exercises, and sometimes it's a bit of a nebulous topic. There are a lot of different exercises you could do. And what you want to do is try to engage the core. So, I have a lot of patients who say, I've got back pain, and I walk, and nothing wrong with walking, but you're not necessarily engaging the core. It would be kind of like saying walking is going to help shoulder pain. You're not really activating, your rotator cuff muscles. So I wouldn't expect it to give much benefit in that regard. So these are just some examples of exercises. As I say, there's a laundry list, and you should find what you tolerate, what doesn't aggravate your pain. And think of it like brushing your teeth. Like every day or every second day, just do 5-10 minutes. Like these are things that I do myself. I don't have AxSpA myself, but I do have back pain. And, I do these kind of bird dog, Superman, whatever you want to call them, cat, cow, dead bug, and glute bridges. I do 3 sets of 10, 3 times a week, and then I go exercise. Doing what other form of exercise I plan on doing that day. But I would encourage anyone with back pain, not just AxSpA as well, to consider doing these and make it a daily habit. The CSA has this handbook. If you don't have it, you could download the PDF version online, or you can ask Wendy on the line, or just email CSA. They could mail you a copy. There are a number of stretches. These aren't all of them in the book, but what I do like about it is they kind of they give you a little practical approach. Do 5 of these, do 3 of these. Hamstring stretch, hold this for 10 seconds. Do a hip flexor stretch. So you want to increase your range, because oftentimes if you have AxSpA, sometimes your range of motion goes down, and increase your core strength. Those 2 things, strength and stretching, I think are important. In terms of efficacy, what do you expect from NSAIDs? Most people with AxSpA will notice some benefit with anti-inflammatories. Although if you look at people with 4 out of 10 pain or worse, so 4 out of 10 or worse pain, only 30% of people will say I'm dramatically better on an anti-inflammatory. So this is the different TNF inhibitors. ASAS 40 is about a 40% response. So these are people who have tried 2 NSAIDs with no benefit. And if you put them on a TNF, about 40 to 50% are going to have a good benefit with TNF. So not everyone will respond. Now, if you don't respond to the first one, you may respond to the second one or the third one. Although the more you've tried and failed, the lower the chance of response. Of course, back pain is actually a pretty common thing. If you do studies of the general population, about a quarter to a third of all people have low back pain. And if you have AxSpA, sometimes you can also have, herniated disc or muscle spasm. And so it sometimes can be tricky in patients with AxSpA. If you treat them and they're not better yet, I would keep, depending on how convinced you are. Sometimes, the imaging is a bit equivocal, and you say, well, let's try it for 3 months, and you tried it, didn't work. Then if you're already on the fence to begin with, then maybe we say, well, we tried it. But if you're really convinced that they have AxSpA, you try the first one and the second one, and maybe even up to a third one, and it's still not responding, then you got to ask yourself, maybe some of the ongoing back pain, if the back pain's this much, maybe this much is from AxSpA and the rest is from another mechanical cause. So that's another possibility, which is why I often recommend people to do those core exercises anyways. Now, most of these patients in these TNF trials had 14 years of symptoms. If you look at people who have less than 3 years of symptoms, you treat them, that the chance of a 40% response is 61%, so higher. And the chance of pretty much remission, this definition is less than 2 pain, less than 2 stiffness. Patients, if they rate, how are you feeling overall from a 0 to 10 scale, less than 2, more than half will have what we call partial remission. So, the earlier you treat, and this is just a slide that I could find, but there's a number of trials of early treatment, and the numbers always look better the earlier you treat. And if you look at people if you divide this group by how long they've had symptoms, you'll see that the early treatment group will do better and the numbers slowly go down. You can still respond if you've had 20 years of symptoms before you get onto therapy, but that chance does go down with time. So when you consider escalating therapy, I would say, those BASDI scores, those 6 questions are helpful, but people are more than numbers. And so I think function is an important thing. If you're missing work, not just to see a doctor, but because of the back pain, or the pain's waking up from sleep, or you stopped exercising and socializing, I would strongly consider a trial of higher therapy, just because most people don't miss work for pain. Like I would say nowadays with COVID, it's not a badge of honor to go to work even when you're sick. But prior to this, I would say I'd never missed a day of work in my life, and I think because this can kind of creep up on patients, sometimes people start losing function, and they say, well, that's just what most, that's kind of normalized for them. And sometimes when you treat them for whatever reason, let's say they have bad skin or bowels, they may often tell me, I don't have any back pain, but then say their gastroenterologist treats their Crohn's and they come back and say, my goodness, I feel like a new person. And that's actually quite common, where patients, they realize how bad they've been feeling all these years and how bad their function has been as well. A little bit less straightforward is if someone has no symptoms or minimal symptoms and their inflammation markers are high, or their fusion is progressing, I would lean towards treatment, just because we know that persistently elevated inflammation markers increase your risk of heart attacks. We don't have a study looking at, are we preventing a heart attack with, say, biologic therapy? We don't know yet. And I think it will be a very difficult study to assess. But, when you look in cardiology world, if your CRP is 4, that has a higher risk of heart attack compared to those who have undetectable CRP. In some patients with AxSpA, your CRP will be 30 or 40. And, even if you have low symptoms, I do worry that, 30 years of 30 CRP will increase that risk of heart disease. So that's all I had prepared for today. And maybe I'll try to address the questions. I see a number here, and I'll, if you have any questions, we'll try to get through as many as we can in the Q&A here. So not in the chat, but in the Q&A. So first question, when biologics have bad side effects repeatedly and fail to reduce pain, what treatment do you recommend for AxSpA? It's difficult, and I think it depends on your personal situation. I think the first question is your disease active? And that can be not an easy thing to tell. The blood markers of CRP are not always positive. 30% of the time they're positive. MRI can be helpful. So sometimes if people are not responding to therapy the way I'm expecting, and I'm convinced they have disease, I'll try the second one or the third one. And if that's still not happening, then I'll repeat the MRI to see, is there any objective evidence of inflammation? Now, if you're getting side effects to the biologic, it depends on the side effect. I kind of mentioned the most common ones. There's also a lot of patients sometimes have unusual side effects, and we don't, it's hard to know. Like in these clinical trials, you have like 500 patients in one arm and the other arm, and you compare them. Those are the only ones you really see a big difference with. But, if someone says, I get bad headaches when I'm on this drug. I mean, I can't say that it's not the drug. I say everyone's different, and maybe it is for you. I don't see a reason why we would expect it necessarily to be with the next drug. So we could try stopping and then switching to a different one and troubleshooting that way. That's probably how I'd approach it. Next question, can biologics impact liver function? Not really, no. PSA was recently taken off my DMARD, sulfasalazine, and anti-inflammatories. Oh, I didn't finish reading that one. Due to suddenly high liver enzymes. So when I say sulfasalazine is not a biologic. Sulfasalazine, it can elevate the liver enzymes, although not as often, but it can. If there's concern with the liver, I don't have any issues with using a biologic. As I mentioned, JAK inhibitors can be excreted through the liver, so you might want to be a little bit cautious with that one. But the traditional biologics don't have any issue there. Now, the other thing with psoriasis, there's a high incidence of what we call fatty liver, metabolic syndrome as well. So that would be something to look into. In our office, we have a FibroScan. Thankfully, one of the patients generously donated that, and that can look for any evidence of liver damage, because you might have elevated liver enzymes, but no actual damage, and then there wouldn't be any concern there. Is there any data how long IL-17 inhibitors can stay effective? Yeah, so with all biologics, a proportion of people will lose efficacy with time. So after about 5 years or so for AxSpA, about half the people lose efficacy. In psoriatic arthritis and rheumatoid, it's about 3 years. And so sometimes you can crank the dose. Sometimes you add methotrexate, because one of the theories is that people develop antibodies that neutralize the medication. And so the methotrexate can prevent that. I usually do that if someone's failed 1 or 2 biologics, because we only have so many options. You don't want to run out of options. You might add methotrexate then, or you switch. What is the criteria to treat AS? Is it safer to take prescribed medication than not take anything at all? So I don't know if there's a criteria per se. I would say the main reason we would want to treat is improvement in pain or function. If someone has a persistently elevated CRP and or fusion that is progressing, I tend to do X-rays every couple of years. I would lean towards escalating therapy. And then if you have little to no symptoms, I don't necessarily think you have to take therapy. I would say that, but like I say, a lot of the times these things creep up on people, and if you notice you're missing work or you're not socializing and you stop exercising the way you used to, I may think about trying 3 months to see what happens. If you're able to mostly control your symptoms through lifestyle changes, is it still important to be aggressive with the treatments? I think that's a similar answer. I would say not everyone fuses. So if you Google ankylosing spondylitis, you often see that Canadian soldier who kind of has a progressive bamboo spine. Not everyone's destined for that. About a quarter of people will get rapid fusion. About another 40% will have some intermediate degree of fusion. And then a lot of people have no fusion, even if you don't treat them for 20 years. So what I do in my own practice, and not everyone does this, but I tend to follow X-rays every couple of years and see, if the spine is progressively fusing, then we have a discussion. And it's still a bit controversial whether biologics prevent fusion. It's hard to prove, because you need to treat someone for 10 years, and it would be unethical to put someone on placebo for 10 years. Needless to say, I think most of the people in the research community feel that biologics do prevent fusion. But most people we don't treat with that main indication. It's mostly if people are not functioning well. And in those situations, we feel that the risk is probably outweighed by the possible benefit. Next question.
Excuse me.
Yes.
Do you have data on a 10-year patient follow-up on biologic, and how did they evolve? Did they have the same proportion of fusion?
Yeah, so the data of the fusion is, so basically there are, the only way we can tell is to compare to historic cohorts. So before we had biologics, there were clinics in Germany and in the Netherlands where they followed people and did X-rays every 2 years, even though we had no therapy. And we can compare those group to the current group now on biologics. And then we do, now the problem is whenever you do a comparison like that, there are possible confounders. And so we do this propensity scoring. So all the known predictors of fusion, baseline fusion, HLA-B27, male, gender, smoking, elevated CRP, elevated MRI, we match those, and then we follow those over 10 years. And so there's been 4 studies showing a 50% reduction in fusion when you look at it that way. We also know that MRI, inflammation on MRI is a big predictor of who gets fusion. So you more inflammation, higher risk of fusion. And we know that TNF inhibitors and IL-17 inhibitors and JAK inhibitors reduce that inflammation there. So, I mean, there's a lot of mechanistic reasons why we think they do prevent fusion. Am I correct in understanding that medication tends to lose its efficacy in 50% of people within the first 5 years? If so, would switching to a different brand of a similar kind of drug, or would the only option be to explore different kind of drugs? So you could, if, you know, there isn't a lot of data about, do you switch to the same class or a different class? In Canada, in rheumatology, one of the gurus is Ed Keystone, and he describes things, type 1 versus type 2 failures. Type 1 failure, take the drug, it doesn't work. Type 2 failure, it works and then loses efficacy. But no one's ever said, is it 3 months of working, 6 months of working, a year of working, and then lose efficacy? What if you had 50% improvement? Is that a type 1 or a type 2 failure? So there's a lot of caveats to this. Needless to say, if someone's done very well for quite a while and then it eventually loses efficacy, I'd probably switch to the same class. But if you had no response to the first drug, I'd probably consider switching to a different class. So how do JAK drugs compare to TNF for non-radiographic AxSpA? There is no data thus far in non-radiographic AxSpA with JAK inhibitors, although, you know, we kind of think there's no difference between the two in terms of treatment. Before any of the non-radiographic studies were done, at least in BC, we were treating people with positive MRIs for years, like negative X-rays, positive MRIs for years with TNFs. And so I probably would consider using a JAK inhibitor as well in the appropriate patient. So Esther's asking, what do you mean by remission? I guess the research definition, and there's a bunch of different definitions, but like partial remission is there's pain, stiffness, CRP, patient global. So people saying 0 to 10, how do you feel? 10 is the worst ever, 0 is nothing. So if all of those categories are less than 2, that is considered a partial remission just in research settings. But I mean, in clinical settings, like I don't necessarily use the research definitions. I would say if patients, feel good, they're pretty happy and they're functioning well, and the pain is 1 or 2 or less, I'd be pretty happy with that as well. So, but it's an individualized thing. I had a patient who is a professional kickboxer. I tell this story a lot, and he competed in K1, and he says, if I do nothing, I don't have any pain, but I've been training all my life to be a K1 kickboxer, so I want to treatment so I can kickbox. And so for him, 0 to 10 at rest was not good enough, and it's individualized. So what's the best medication to treat Crohn's? Good question for a gastroenterologist. I don't know if I can answer that one. I know, TNF and IL-12/23s, IL-23s, JAK inhibitors all been shown, but I don't know which one's better. Do you agree with pain patches for spina bifida arthritis? I don't do a lot of just mechanical or other back pain. I would, once we get into opioids and pain patches, I tend to refer to the pain clinic. Unfortunately, I'm probably not the best one to answer that question there. Is bone marrow edema on an MRI confirmation of AS? It depends how much. So it's a surrogate for fluid. Now, the definition we've used in research is 2 bone marrow edema lesions on 1 slice of the SI joints, or 1 lesion seen on 2 consecutive slices. Now, if you got a ton of bone marrow edema, that is quite specific for AxSpA, with the exception of infection, fracture, and cancer. So those are rare but possible causes of severe bone marrow edema. And you should be able to tell that on the MRI. The radiologist should see, okay, actually this is like extending into the muscles, and actually there's like a huge pocket of fluid like right over the muscles there. That would be an abscess, right? Now, low levels of bone marrow edema are not diagnostic. So we've done studies looking at people asymptomatic. About 5% have that mild bone marrow edema. People with mechanical back pain, about a quarter. Athletes, they looked at the Danish hockey team, national hockey team, and 40% of them had a little bit of bone marrow edema. So if you have a little bit of bone marrow edema, I think you need more clinical features before I say that is AS. Hey, Parker, are there treatment options?
Excuse me. Yeah, excuse me. We don't have much time. I'm just like, I need to ask a frequent question. So
Sure.
we've already heard it. It's COVID time. Are patients on Humira or Biologics at higher risk of getting COVID and or doing worse with more severe disease symptoms if they get COVID?
Good question. So there's an international registry right now. Derms, rooms, and GIs can upload clinic or patient cases of people with rheumatic conditions who get COVID. And so they compare those who get COVID who are on a biologic and those who are not, and then they match them for comorbidities. And there does not seem to be worsening disease outcome. And by worsening, I mean hospitalization, intubation, or death. Doesn't seem to be an increased risk on a biologic. Now, a couple caveats to that. I think people on a biologic tend to be more cautious, and rightly so. And so I would not say this is a ticket to be cavalier about it. I think if anything, it's reassuring. You don't have to worry and be too anxious about it, but keep being cautious. Wash your hands, wear your mask and social distance and do all the things that your health department is suggesting you do. But it doesn't seem that people are doing terribly poorly on these medications. Prednisone, 10 to 20 milligrams, has been shown to increase your risk of hospitalization and death. Although interestingly, if you're on prednisone and you get COVID, that's bad. But if you got COVID and then you have a lot of people who are intubated get this post-inflammatory syndrome where your immune system reacts to the COVID. In those situations, you want to give prednisone or dexamethasone, I should say, and actually that improves mortality. So it depends on the timing, but in general, it's pretty reassuring what we're seeing for the biologics so far.
And if we get minor symptoms from COVID, should we anyway stop the injections?
Yeah, I would. We don't know the right answer. I had a patient today who called me and said, "Oh, I got COVID. I'm better now, but should I stop it?" I said, "Well, you already got better, so don't stop it." But if you like your partner or your kid or whatever gets COVID, and you start getting symptoms, I probably would stop it then.
Okay, thank you. Maybe one more question.
Sure. I'll just go to the next one. Are there treatment options being explored that will take patients off regular biologics? Yeah. So, tapering. That's the next frontier. In rheumatoid, we got some great studies there. If you treat early, so in established AS, people who've had 10 years or more symptoms, they did studies where people were in remission for 2 years, stopped the drug, it all came back. There's recently a study in established AS where treated for a year, people were in remission, and then they randomized them to continue on the regular dose, cut the dose in half, or stop. Those who continued or cut the dose in half were equal. About 85% of people still remained stable, but those who stopped the medication, 80% flared. So, if you have established disease, high chance if you stop the medication, it does come back thus far. Non-radiographic studies, so MRI positive, X-ray negative disease, study where patients who got remission sustained it for 6 months, and then half of them continued, half of them stopped. 40% of patients were still in remission even when they stopped the medication. So if you can catch it early, maybe there's a chance. Like in rheumatoid, if you wait like 10 years, you're never going to stop your meds. But if you catch it within 3 to 6 months, there's a 40% chance you can get into drug-free remission. The trouble is in AxSpA, there's a 9-year delay. So almost no one gets diagnosed 3 to 6 months into disease. And so it's a bit of a challenge there. But that's kind of the next stage of where we're trying to move with therapy is cure. Right now we can get into drug-induced cure, but we're not quite at drug-free cure.
Last question. It's actually a personal question, a research question. What would you advise a JP so like he would think or do not to miss an AS patient?
Yeah, I think part of the problem is we give them mixed messages. We say, don't order the B27, and then we do this inflammatory back pain history. But now I think the B27 is a very good test. And so what I tend to do is if someone's got, or what I recommend, if someone's got more than 6 months, 3 to 6 months of bad back pain, then I would order a B27. If they've got uveitis, psoriasis, or Crohn's colitis, and they're young and they got back pain, because 99% of people are going to start getting symptoms before age 45. So if they're young, and by young under 45, hopefully I didn't offend anyone, but if you're young, you got any one of those 4, so uveitis, psoriasis, Crohn's colitis, or positive B27, they should see a rheumatologist. If they've got a lot of stiffness and pain's better with activity, that's something also kind of that inflammatory sounding feature, then, that might also be reasonable. Although a lot of mechanical back pain will also kind of have some stiffness and better with activity. So it's not that specific.
So when would you use an MRI that is centered on the sacroiliac?
Yeah, so any one of those 4, I would get an MRI. And if someone's got a pretty, inflammatory sounding back pain history, I would probably get an MRI as well. Yeah.
Thank you so much, Dr. Chan. Everybody enjoyed the presentation. We're so grateful to have you here tonight. Thank you so much.
My pleasure. Yeah.
Just a reminder for everybody to fill the questionnaire, the survey that we're going to send you. Thank you all for joining us tonight. Hope to see you soon on the next webinar.
Sure, yeah. Sorry I couldn't get through all the questions, but maybe I'll stop talking earlier.
You did as much as you can. Thank you so much.
All right. Have a good night, guys.
Good night.